right. Well, I want to say welcome to the folks who are here. We're excited to have another HIMF seminar here on Friday. And before we begin, I do want to acknowledge here at the University of Victoria, we acknowledge and respect the Lekwungen peoples, Songhees, Kapasim, on whose territory the university stands, and the Lekwungen and Song and Wasanich peoples whose historical relationships with the land continue to this day. We have many folks joining us from different places, and so I encourage you to take a moment to think about the land from which you are joining and your relationship to that land. I'm really excited for our topic today. I always love hearing about actual implementations versus just the planning pieces. So I'm looking forward to hearing our speakers today. Without further ado, I'm going to go ahead and turn it over to our speakers. Thank you again.
Thank you for the invitation. I'm going to share my screen first. So thank you very much. Thank you again for the invitation. We are very excited to share our work done at the Center for Addiction and Mental Health titled Co-Designing Implementation Strategies for a Suicide Prevention App with Clinicians, Patients, and Care Partners. And my name is Danielle. I'm a registered nurse and I'm a postdoc at Harvard Medical School and Brigham and Women's Hospital. And we'll hand it over to Gillian, and then I will join later.
Yeah, thank you very much, Danielle. And also thank you to Dr. Courtney and the team at the University of Victoria for the invitation to be with you here today. So I work at the Center for Addiction and Mental Health in Toronto, Ontario as the Chief Clinical Informatics Officer. That's my administrative role. But I'm a scientist, a registered nurse, and do research in this digital health space. And so we'll go to the next slide because over the course of the next, I'll say little while because we don't have this time down to a T for the exact amount, but we'll leave some room at the end for conversation with you. We have this as our outline, so a bit around the background and then sort of the traditional aspects of going through a research study. And this was Danielle's study that she did as a part of her PhD work, which she finished. And I was just thinking about it. It might have been a year ago today that she defended her PhD thesis. So we'll go to the next slide. So the background is the organization that I work at, that Danielle did her PhD at, is one of a number of mental health organizations that provides clinical care in Canada. And we have an emergency department present. This is one area that's a really important area for suicide prevention because we know that from the records that have been kept on individuals who have died by suicide, a large number of individuals who have died by suicide have come into contact with the healthcare system in a short window prior to their passing. In the ED, we get people who are in crisis. We have a psychiatric emergency department at the organization where we get people when it's a time where we can implement interventions that may be life-saving. They either can be admitted to the hospital or followed through discharge or discharged home, or sorry, followed through a clinic or discharged home. We want to make sure that we equip them with their right skills, interventions, et cetera, so that they can be safe outside of our care. One of the best practices in this space, there's a number of best practices in this space. One of the best practices in this space is a suicide prevention, a safety planning intervention that is done between providers and patients and coming up with a unique plan for that individual to keep them safe. We know that suicide is a public health emergency in not just Canada. It's an issue around the world. And in fact, we see close to 4,500 deaths per year by suicide. And you can see a number of really tragic statistics on this page around some of the numbers. But I always find we can spew off the numbers about this. We can tell you the numbers, but unless you've had and all of us have likely had someone we know or been impacted in some way by someone who has died by suicide. And it's just, it's such a tragic thing that can happen. And it's hard to even give the background section for this without being able to take it back to that personal level. So we'll go to the next slide. This slide is really around the safety planning intervention. So generally, safety planning interventions traditionally have been done on paper, so that someone can carry it around in their pocket. It's usually done between an individual who's at risk for suicide and their clinician and maybe a family member, where they look at things like warning signs, coping strategies, who to contact. It could be 988, having it handy there. It could be about restricting lethal means. There's a number of different components that are traditionally part of safety planning interventions that have good evidence behind them. We can go to the next slide. One of the challenges, though, with the paper-based safety intervention is that you can lose it, can become out of date, you can't share it very easily. It can get, you get wet, you put it through the laundry in your pocket, and then it's gone. So you can think of some of the challenges with the paper-based safety intervention. And so at our organization, there was an innovation expo where individuals who are staff at the organization could put forward ideas that they thought might be innovation ideas that could solve some big problems. And one of the ideas that came through was this idea of creating an app for the safety planning intervention to replace the paper-based safety plans that we had currently been using. So that is the winning idea. There are a number of submitted ideas. This team won the Innovation Expo. They got a bit of funding, and then we started working with them on the evaluation and research, both in the co-design, co-development, and evaluation perspective. So there is a number of clinical experts, patients and family members, and then members of our legal privacy and security team that really came together to actually develop the app. And then there was a number of more QI PDSA cycles of iterating on the app. We'll go to the next slide. So what is this app? So this app is actually available in the Apple App Store now. It used to be available in the Google Play Store. We're having some issues with that, so hopefully it will be back on there in the not too distant future. It has some of the traditional components of the safety plan, but it also has access to a number of resources, wellness activities, general information, and then immediate access to either call 988, 999, or other resources. So that is the app, and it is available free currently. You can go to the next slide. So the setting in which Danielle was looking at for her PhD work in implementing the app was our emergency department. And so it's one of the largest, we believe it's the largest mental health teaching hospital in the country. We have not quite 600 inpatient beds. We do have a standalone psychiatric emergency department. The paramedics or EMS, pull right up to our doors. We get up to 1,500 adult patients every month. We do have some youth, but we don't have a pediatric emergency department. And there is a 24/7 psychiatrist coverage model. And as you imagine, an interdisciplinary team with nurses, program assistants, psychiatrists, lots, because we're affiliated with a university, lots of residents and medical students, social workers, and pharmacists who are present. Go to the next slide. So why embark on the work that you're going to hear about in a moment? Even though this app was available and we'd sent some emails and a few educators had talked about the app, and even one of the head of the emergency department was involved in developing the app, there was a limited implementation or adoption of the HOPE app by the clinicians in the emergency department. As you can see from the strategies I just mentioned, there weren't necessarily tailored strategies for how to actually integrate the app into the ED setting, which is quite unique than an inpatient ward or an outpatient clinic visit. And so there's really a need to do just that, to come up with some way to uniquely tailor the implementation plan to the emergency department. So go to the next slide. So the research objectives, and Danielle, I think I transitioned to you at the methods slide, but really the research objectives for her PhD were these three that are on this slide, but we're going to focus on the third one. So the first one is really, looking at the literature on what are some of the digital interventions for suicide prevention in clinical settings, including the ED, but not just the ED. The second one was around clinicians' experiences and perceptions of implementing the HOPE app already and into their practice to get a sense of some of the barriers for facilitators. And then for today, you're going to see objective 3, which is actually starting to co-design those implementation strategies. So really getting at the let's go do it. I'll pass it over to Danielle now.
All right, thank you. I will go through high-level methods, but if anyone's interested in learning more about the details, here is the paper. You can take a look. But the one major theoretical framework that guided the whole research was the behavior change wheel by Susan Mickey. As you can see on the slide, the behavior change wheel has multiple components, but the green core, which represents capability, opportunity, motivation, and behavior model, which the left corner visualization is a different representation of the combi, but it provides a really important assumption about our human behavior change that capability, opportunity, motivation interact in a complex way with the arrows that you see that shape our behavior. So in order for us to think about practice change, behavior change, individuals need to have necessary capabilities, including knowledge, skills, the motivation, the beliefs and values, and also external factors, the opportunity, the physical environment, resources, time, and social culture and norms. All of these things are really important when we are thinking about behavior change. And absence of any of these necessary combi determinants that are specific to a target behavior, then that behavior change may not occur. And the reason why I'm really focusing on behavior change approaching implementation through the lens of behavior change is really important because for this context and for these objectives, the end goal of implementing or integrating this new app modality for safety planning intervention requires changing clinicians' practice. So instead of bringing the traditional template of safety planning, clinicians need to instruct patients and to collaboratively develop and complete safety planning using the app. So that requires a behavior change. So that's why the Combi is providing a very comprehensive analytical tool to better understand what are the determinants that will shape clinicians' practice. And the red ring on the behavior change wheel, so not only this is an analytic tool, but it also informs our design process. It provides suggestions in terms of what specific intervention functions or the solution types, such as training, modeling, education, or restriction. These specific functions are suggested for specific combi domains, so which I will get into during the results. So in previous research objectives 1 and 2 that Gillian has mentioned, it's about understanding the context, understanding the potential barriers, actual barriers, and facilitators. We have identified a list of barriers and facilitators and have mapped onto the combi, and that worked as it was our knowledge base for designing our tailored solutions to support clinicians so that can use the HOPE app with patients. Some of the barriers, which I will also touch on during the results to share how each specific techniques were selected for which barrier, but examples include limited awareness about the app or the beliefs and values or the perceived benefit of the app or anticipated workload changes with the new modality. So there were multiple partnerships in this research. There was the advisory committee, which included the emergency department medical head. And also I consulted with patient advisory committee at the organization to get some insights about how to to design these co-design meeting sessions, get their insights about what is the ideal way, so then I can optimize these co-design sessions. And then finally, the co-design team um, included 12 members in this study, including nurses, psychiatrists from the emergency department, also social worker, and patients and friends or caregiver partners. And they joined the design sessions, and we built, developed, designed these specific solutions. So there were 4 design sessions. We met online through May to September in 2024. And again, the behavior change wheel was the theoretical backbone, making sure the alignment between our selected ideas and solutions to the specific barriers that are modifiable. And then we also used public patient engagement evaluation tool to assess our co-design team members' experience at the end of each design session to ensure and to monitor their experience. And so therefore I can make necessary changes to optimize their experience. And so prior to meeting as a team before the design session number 1, I also had one-to-one orientation session with all members of the team to make sure that everybody's on the same page and they are clear with their anticipated goals and expectations in terms of what they are asked to do in these sessions. So as you can see, each meeting had different agenda, but these sessions were designed so that each session findings fed into the next one. So as a team, we first understood the implementation problem as a team. I shared the list of barriers and facilitators that we are aiming to target and had a brainstorming discussion around what is modifiable. And then in the second design session, we identified intervention functions and specific behavior change techniques for targeting specific barriers. And then we brainstormed in terms of what that strategy or solution looks like. And then the third session, I presented their ideas in an organized way. And we evaluate those 11 different implementation strategies against the APEAS criteria, which stands for affordability, practicality, effectiveness, appropriateness, safety, and equity. And then we further made refinement. And then the fourth design session, I presented the final list of strategies, and they had opportunity to make final recommendations. So I won't have time to go through all strategies, but I will share major ones. But if I will share the papers, which includes all 11, and also has more details in terms of specific techniques and the rationales for selecting rationales behind our decision making. So you can take a look at those. But so here are some major ones. So the first one combines education, training, and persuasion. So what you see on this slide, right upper corner table, is a behavior change wheel matrix. The green column represents the COMBI model that I introduced you in the beginning, and which lists the capability, opportunity, and motivation. And the red row represents 9 different intervention functions, which are types of solutions that we need to think about. And then the navy color boxes mean that that specific intervention function is recommended for that specific COMBI domain. So the yellow boxes represent what was selected in this particular implementation strategy, which is education, training, and persuasion. And as you can see on the table, education and training were selected to influence psychological capability, the knowledge and skills of the clinicians about the HOPE app. And then the persuasion was selected to influence their motivation. And the team suggested that we need to develop a HOPE app module in the form of a slide deck, which needs to be included in the emergency department orientation as part of the suicide prevention module. and the specific techniques included in this slide deck was providing information about health consequences, the impact of safety planning, and that it can reduce the risk of engaging in harmful behaviors by up to 45%, and also providing instruction on how to perform the behavior, which is we included clinician script on how to introduce the Hope app to their patients, and we also had a screenshots included in this module to show how to navigate the Hope app, because the clinicians need to have that skill to demonstrate how to navigate the HOPA when introducing this to their patients, and also include incredible source of the systematic review reports of the safety planning intervention. So the rationale behind was that there was a limited awareness about the Hope app. We learned through the prior work that there was a frequent turnovers in the ED. So new staff there, they didn't know about the app unless they heard about regular communication letters. They were aware of this app, but then there was some way to continuously or in a routine way that we need to communicate about this app in the department. So that was the idea, and to really influence the motivation and the beliefs about the impact of using this tool, we selected these particular techniques. And also, I believe we also included Hope app user testimonials as a way to persuade clinician and to influence that motivation piece. And then the next strategy combined education, training, and enablement. Again, the education and training were selected to influence the psychological capability, the knowledge and skills, but enablement was selected to provide that opportunity for learning and building skills. So the idea was that we need to utilize emergency department morning huddle every shift to take time to educate and try out the contents of the app. So we are creating that physical time and social opportunity for trying out and to learn about this app among the ED clinicians. So the specific techniques selected for this strategy was social support. So we are providing this practical opportunity to learn, and the behavioral practice and rehearsal too. So then clinicians are trying out this app on their own device. It's giving their opportunity to rehearse what it's like to navigate, which they should later can demonstrate to their own patients. And we are again providing the information about health consequences to further educate about the impact of the safety planning. And also I forgot to mention that the second table, the green, it represents the appease rating scores from the design team. And then the next one combines coercion plus environmental restructuring. Coercion is more like a forcing function, which is selected to influence the autonomic motivation, the habitual behavior break, because in the busy ED setting, when it's busy, it's a human tendency to fall to the old way of doing things or the traditional way of doing things. So to break the habit, we selected this function, and then we also selected environmental restructuring to influence the physical and social environment, and also to further break the habitual behavior change. So the idea was that to build simple EHR documentation for the delivery of safety plan. The rationale behind this strategy was that we learned from the previous work that there was no standardized way to communicate the initiation of safety plan in the ED. Oftentimes, clinicians find out that safety plan was initiated by going into the patient's room and finding the paper template. So the team suggested that we need some standardized communication way process for the initiation, and it also learned that nurses, social workers, psychiatrists, any of them could initiate safety planning. So they suggested more organized communication method for the initiation. And so the documentation of the safety planning intervention was very important in this department. And traditionally they scan the copy of the paper, the safety plan, and that scanned copy gets recorded on the patient's chart. So it was identified that there was some need for forcing function to ensure the safety plan is delivered for all eligible patients who come to ED. So the idea was that we need these check boxes for this department. So whether or not the safety plan was delivered and what method of what modality was delivered, because we couldn't get rid of paper entirely because of some people um, who um, who need this paper alternative modality, because some do not have small, but some do not have smart devices. And so this is the techniques include or reflected here is the restructuring the physical environment, changing the EHR system around the environment, and behavioral contract, which is the forcing function, and restructuring the social environment. By creating this, we are restructuring the communication around safety plan delivery in this department. And then the next one is the last but not least that I will share with you today is environmental restructuring plus enablement. The environmental restructuring was selected to influence the physical and social opportunity and autonomic motivation, but enablement was selected to influence psychological capability, mainly reducing cognitive load for busy clinicians. So the idea was that because if we build that check boxes, we can make use of the alerts and as a reminder. And the techniques here are reflected here are prompts and cues. The alerts are nudging functions, and so we are conserving mental resources, especially by having a reminder, we can help conserve mental resources or cognitive load for clinicians. And then this is changing the physical environment. And so, but as you can see on the second table, a peace rating score, there was some uncertainty around the acceptability of this function. And we kind of know because there are also a lot of alerts in the department. And this slide is busy, but just to share the evaluation of the co-design team members' experience. So using that public patient engagement evaluation tool, it was rated on the 1 to 5 Likert scale. I asked each member about their experience with communication and support for participation at the end of the session, and also their experience with sharing ideas and their perceived impact, and whether or not they felt comfortable sharing their ideas, and whether or not they saw the anticipated impact on how their insights are being how their insights are really informing the strategies that we are developing on, and what are some of the changes that we are making. But what was more helpful for me to know was their narrative comments that they filled out at the end of each session. So that was helpful for me to monitor their experience about what was helping, what prompts were helpful for getting the discussion, and what anticipated impact they were seeing, and how their insights are shaping the implementation strategies, making sure that what is feasible in the emergency department. And some also commented about how they appreciate learning different perspectives because we brought, clinicians and patients and care partners in one space. So in conclusion, co-design, collaborative approaches, and suicide prevention research is important in implementation studies, and it's feasible. They have the patients, clinicians, and care partners. They have a lot to offer. So not only in the intervention design, but which oftentimes happen, and I think it's more standard now that they engage with people when developing new intervention, but it's also really important to involve them during the implementation process or the designing of the delivery of an intervention. So, and they have a lot to offer and to shape how that new intervention or new modality of an intervention can be delivered. And but as a next step, future testing and monitoring is required to really assess whether or not that those implementation strategies are changing clinicians' behavior. And the way to do that is to look at observable behavior changes as well as proximal behavior changes, such as knowledge, skills, as the combi domains. And then the also as a which was also the reflecting on the collaborative approaches of doing this research engagement evaluation throughout the design session was helpful to gauge participant experiences and the needs, and that helped me modify and make small changes throughout the design sessions so that I can optimize their experience, because more comfortable, more engaged they are, we can have rich discussion, and those insights are really shaping implementation strategy. And then I want to end by saying that this engagement is to continue after study ends. So this work is published. Here is the paper if anybody is interested in learning more about these 11 different implementation strategies with the rationales behind these techniques. And each, the rating, the piece scores are also included in this publication. So thank you. I want to also say thank you to my committee and research team's support to notes during the sessions, and also the co-design team. Of course, without their insights, we couldn't design these 11 different implementation strategies, and also the funding agencies for providing financial support. So thank you very much. And we'll stop here and go into discussion and Q&A.